All right. Well, again, good morning, good afternoon, or good evening. I'm going to be sharing with you the importance of the spinopelvic relationship. These are my disclosures. So what is the desired cup position? Well, I've been at this for a number of years, and I was taught that in every patient you put the cup in the Lewinick safe zone, and this is based on an article in the Journal of Bone and Joint Surgery by Lewinick all the way back in 1978. And he analyzed 300 hip replacements, and he stated that if you place the cup in 40 degrees plus or minus 10 degrees of abduction and 15 degrees plus or minus 10 degrees of aneversion, you would have lower dislocation rates. But if you actually analyze his paper, there were 3 dislocations that were actually within the safe zone. Well, about 5 years ago, the Mayo Clinic, in this article by Matt Abdel, kind of took the Lewinick safe zone to task, and they analyzed nearly 10,000 hip replacements done at the Mayo Clinic and then studied the cohort that dislocated. And interestingly, 58% of their dislocations occurred with acetabular components placed within the safe zone. Well, back in AUKUS in 2017, Jonathan Vigdorchek and myself, there was data analyzed in 300 patients undergoing hip replacements that had preoperative functional imaging using the Corin optimized positioning system, or the OPS system, which involves sagittal pelvic radiographs, as you can see in the lower corner, standing, flex seated, and also a step-up maneuver. And lastly, also a CAT scan. Then using this system, the ideal individualized cup position was determined. And we compared that cup position with the Lewinick safe zone. And isn't it interesting, only 56% of the individualized ideal cup position was placed within the Lewinick safe zone. So why is all of this important? Well, in an article by Novikov and Vigdorchek, they looked at 117 revision hip replacements analyzing the modes of failure. And they divided the failure modes into 2 categories: avoidable, 51%, and unavoidable, about 49%. But interestingly, in those avoidable failures, nearly half were associated with suboptimal cup position, many of which were associated with unaddressed spinopelvic pathology. So certainly, adverse spinopelvic mobility patterns certainly play a role in revision total hip arthroplasties. Well, more recently, Larry Dorr and others have coined the term the functional safe zone, where actually the safe zone is based on the cup position based on each individual patient's spinopelvic mobility pattern. In other words, you're not placing the acetabular component in the same position for each patient. So why consider all of this? Well, it is now well known that abnormal spine motion patterns can drive the pelvis into functionally abnormal position that are not predicted from a routine supine AP pelvis radiograph. I mean, for decades, I have made a lot of my planning decisions off a supine AP pelvis radiograph. And there are a number of studies that show that for each 1 degree change in pelvic tilt in the sagittal plane, there is a 0.7, 0.8 degree aneversion change. And therefore, if you have a 13 degree change in pelvic tilt, this will result in a 10 degree change in functional aneversion. Now let's look at the diagrams below and focus on the 2 in the center. Here, a cup is placed in a 40, 20 degree position, and as you can see, sagittally, the pelvis is in a neutral position with no anterior or posterior pelvic tilt. Now the 2 on your left, Here, the pelvis has 13 degrees of anterior pelvic tilt. And look at the change in the orientation of the acetabular component. Forward flexion or anterior pelvic tilt in the sagittal plane results in a decrease in both acetabular cup inclination and anaversion, more so in anaversion. And here you can see a 10-degree reduction in anaversion compared to the case where the pelvis is in the neutral plane. Now on your right is just the opposite. Here the pelvis is tilted posteriorly 13 degrees, and here you can see that posterior pelvic tilt in the sagittal plane increases both the inclination angle as well as anaversion. So here, with 13 degrees of posterior pelvic tilt, there is a 10-degree increase in anaversion. I'd like to quote this article. I think it really is a landmark article by Jim Pierpont, who is one of the brightest orthopedic engineers that I have met in my career, as well as a number of the Australians that make big contributions to the OPS system, particularly Andrew Shimon. And they looked at over 1,500 hip arthroplasties that had all undergone the same pre-op OPS analysis. And they analyzed the effect of pelvic tilt on three-dimensional functional acetabular component position. In other words, they looked at positional changes and what effect they had on acetabular component position, assessing patients in the supine position, the standing position, and in the flex-seated position. Well, what did they find? Well, 17% of this large cohort, the pelvic motion patterns could result in an unfavorable cup position. And interestingly, that data is based on us, the surgeon, placing the cup in the perfect position every time, which we know often does not happen. And if they added in a 5-degree surgeon insertional error, the patients at risk now went up to 51%. Now, Andrew Shimon, who's from Melbourne, Australia, and I've learned so much from him, he actually has taken the same database, and the analysis has been extended now to nearly 10,000 patients, again, to determine the prevalence of patients who have adverse spinopelvic mobility patterns. And I will give you part of the answer right away. There are wide variations from patient to patient in both the direction as well as the magnitudes of spinopelvic mobility. So what did their data show? Well, if you go from supine to standing, on average, there is a 5.2 degree posterior tilt of the pelvis. Now, when we look at the change in pelvic position from standing to flex-seated, on average, there wasn't a lot of change. But in both positional changes, look at the wide variation in the range of the pelvic sagittal position change. If we look from supine to standing, some patients' pelvis tilts posteriorly 20 degrees, while others tilts anteriorly 10 degrees, a 30-degree range. And it is even more magnified as far as the variability when going from standing to flex-seated. Some patients, when they do this maneuver, their pelvis tilts posteriorly 40 degrees, while others, their pelvis tilts anteriorly 40 degrees, an 80-degree range. So there are large variations in the sagittal pelvic positions going from one position to the other. So what is the definition of adverse spinopelvic mobility? Well, there have been a number of articles that have now been published that really give us guidance what adverse spinopelvic mobility is. You know, the take-home message is really how much pelvic tilt will take a perfectly positioned cup in the AP supine position out of the functional safe zone. So here, if we look, one of them is posterior pelvic rotation in the sagittal plane more than 13 degrees from the supine to standing position. And here you can visually see as this happens, the anterior aspect of the femoral head is uncovered. You can incur posterior impingement of the femoral neck on the acetabulum, which results in edge loading of the polyethylene anteriorly and even subluxation or dislocation. Another adverse mobility pattern is anterior rotation of the pelvis of greater than 20 degrees from a standing to a flex-seated position. And here you can see the opposite happens. Look at how much anaversion that cup now has. And in contrast to the posterior rotation, the patient who is the big forward flexor of their pelvis uncovers the posterior aspect of the femoral head, risking posterior impingement of the neck on the acetabulum and subsequent posterior edge loading, subluxation, and dislocation. So why is all this important? Well, again, if you have posterior rotation of greater than 13 degrees from supine to standing, it will antivert the cup greater than 10 degrees. So here, your 40-20 anterior supine position now places the cup outside of the traditional safe zone that many of us have used for years to position our acetabular components. And again, if we remember, when we go from supine to standing, on average, there is a 5.2 posterior pelvic tilt. So what does that result? It takes that 40-20 cup in the supine position to a 42-degree, 25-degree anteverted cup in the standing position. But what happens if you have a forward flexor with anterior rotation of greater than 20 degrees from standing to flex-seated? This will actually retrovert the cup greater than 15 degrees and place the anaversion less than 10 degrees. So here, the cup is outside of the traditional safe zone, but in a different direction, risking posterior dislocation. So what about the prevalence of these adverse spinal pelvic mobility patterns? Well, if you look at the red shaded area, in this large database of nearly 10,000 patients, 5.5 demonstrated an abnormal posterior rotation of the pelvis greater than 13 degrees, placing these patients at risk for problems in extension. Again, in extension, posterior impingement, and risk of anterior dislocation. Now, if we look at the blue shaded area, there were 9% that were the excessive anterior pelvic tilters that rotated greater than 20 degrees. So 9% of patients were at risk in flexion, risking posterior edge loading, subluxation, and dislocation. And interestingly, there is a small percentage of patients, 1.2%, that actually demonstrated adverse spinal pelvic mobility patterns in both extension and flexion. So therefore, in this large database, and this is data assuming the surgeon has placed the cup in the perfect position, 13.3% demonstrated adverse pelvic mobility patterns. But again, as I have already stated, we know that as surgeons, we often have surgical errors greater than 5 degrees. And if you actually look at some of the sophisticated robotic and other types of imaging systems to help drive us to put the cup in the right position, a 5-degree surgeon error is an acceptable thing. Well, if you add that to their database, the percentage of patients at risk is substantially magnified. So now let's move on to other issues. What about intraoperative patient position on the operating table? How accurate are we? Well, out of, again, one of the Vigdorchik studies, they compared surgeon predicted cup position with the true cup position determined from a CT-based robotic navigation in 100 total hip replacements done in the lateral decubitus position via the poster approach. And they assured there were, quote, rigid patient positioners to hold that patient in the desired position. Well, how accurate were surgeons in predicting the accurate position of the cup? Well, surgeon predicted anaversion error of greater than 5 degrees occurred 41% of the time, and greater than 10 degrees in nearly a quarter of the patients. As you can see, we're a bit better in predicting inclination. So we are not highly accurate in the determination of intraoperative pelvic position, and all of these intraoperative guides that we have used for years assume a known and precise pelvic position. Well, Houston, we have a problem. We even have more problems because Nishihara has shown even if you do know the exact pelvic position, the pelvis moves during the operative procedure. And they, using computer navigation, assessed the position of the pelvis before and after the hip was dislocated posteriorly and found that there was a 12-degree change in mean posterior pelvic tilt. So the position you start with is not necessarily the position of the pelvis that you end up with during your procedure. And I'm again going to hammer away with some summary slides, and this is one of them. Remember, there is a dramatic change in cup orientation based on sagittal pelvic position. And when the pelvis in the sagittal plane tilts posteriorly, you will get an increase in both inclination and anaversion. And as it flexes anteriorly, there is actually a reduction in inclination and anaversion. So here is a case example. This was a patient referred to me 2 years after her hip replacement with the chief complaint that every time I tie my shoe, my hip clicks. And let's just first focus on the AP pelvis x-ray. And in my hands for years, if I had a AP pelvis x-ray that looked like that, I think that I did a fairly good job. I think based on that, the components look to be pretty well positioned. But now let's look at the sagittal lumbopelvic imaging. And you can see, number one, that she has a 3-level lumbar fusion. And when she is standing, she has about 10 degrees of posterior pelvic tilt, a risk factor. Number two, when we look at the flex-seated view, she's a big anterior forward flexor, and anterior tilts 20 degrees. So overall, when she goes from standing to flex-seated, she has 30 degrees of anterior pelvic rotation, and as you can see, a near total loss of cup anaversion. And looking at that x-ray on your right, it's pretty easy to understand why her hip clicks, because as that cup functionally retroverts, the anterior aspect of the femoral neck impinges on the anterior aspect of the acetabular component. Let's now talk a bit. This was an article by Larry Dorr that caught my eye on people who dislocate late. And they reported on 20 patients that dislocated late, an average of 8.3 years after their total hip arthroplasty. They found 9 that had dislocated anteriorly and 11 that had dislocated posteriorly, and they did a similar spinopelvic motion analysis on these 20 patients. And Dr. Dorr has described the spine-pelvis-hip complex as actually two hinges. There is a posterior hinge, or the lumbosacral junction. And when we actually sit down, normally about 20 degrees of the flexion occurs at the lumbosacral junction. But then there is the anterior hinge, or the hip joint. And again, while sitting, about 60 degrees of the bend that is required to sit occurs at the hip joint. But both this study and others have shown that if you have a stiff anterior hinge, a stiff hip, if you have a stiff spine, the posterior hinge is stiff, the hip actually has to compensate. And it has been well documented that when you go to that seated position in patients with a stiff lumbar spine, their hips actually have to flex more and puts them at risk for impingement and dislocation. But the opposite is also true. If you have a stiff hip, there is more load and motion that has to occur at the lumbosacral spine. And I personally believe this is one of the reasons why after you do a hip replacement, those patients that have had chronic lumbar pain, a substantial percentage may often tell you, well, you know, my spine now feels better. And this is why I think that is the case, because you have provided mobility to the anterior hinge, the hip, so that there is less stress transmitted to the lumbar spine. And when they looked at the spinopelvic mobility patterns, 90% of these late dislocators, 8 of 9 of the anterior and 10 of 11 of the posterior, demonstrated adverse spinopelvic mobility patterns. So now let's just look at these 3 patients. And on your left, in the standing sagittal view, you can see the pelvis is posteriorly tilted 29 degrees. The patient in the middle has a neutral pelvic tilt, and the patient on your right in the standing position, their pelvis is anteriorly tilted 18 degrees. And if you look at the 3-dimensional models below, you can see in each case the acetabulum is in a different position. So are you going to place the cup in the same position for all 3 of these patients? Well, I hope at the end of this presentation, your answer to that question will be no. We now have been benefited from a lot of research in the spinopelvic arena, and there are numerous articles that have really helped us to understand and define which patients are at risk due to adverse spinopelvic mobility patterns. And one of these is the patient that has standing posterior pelvic tilt of greater than 10 degrees. Number 2, pelvic change from supine to standing of over 13 degrees. Pelvic tilt change from standing to sitting greater than 20, which I have mentioned. Number 4 is the stiff lumbar spine. And it's that patient that goes from standing to flex seated and demonstrates less than 20 degrees of lumbar flexion, have been shown to have significantly higher dislocation rates. And as I will chat a bit later, we're going to talk about sagittal spine balance. And those patients that have severe sagittal spine deformity or imbalance, measured by taking the patient's pelvic incidence minus the standing lumbar lordosis, and if there's a 20-degree mismatch between those 2 values, they are at risk with a dislocation rate of 8%. Let's now talk about the stiff lumbar spine, and we'll start by talking with spine fusion. Buckland and Vigdorchek, Buckland the spine surgeon and Jonathan the hip surgeon, published a nice study where they studied dislocation rates in the Medicare database, looking at a large number of patients, and those subjects that had no lumbar flexion or no lumbar fusion had a dislocation rate following total hip arthroplasty of 1.55%. If there was a 1 or 2 level fusion, the risk nearly doubled to about 3%, and if over 3 levels were fused, it nearly tripled to 4.12%. The Mayo Clinic has done a similar analysis from their Mayo registry, and they identified 58 patients who had a preoperative lumbar fusion. Well, they took this cohort and matched them in a 2-to-1 ratio with total hip subjects that had not had lumbar fusion. Their dislocation rates at a year in the non-fused group, very similar to the Medicare database data, 1.6%. But those that had a lumbar fusion, the dislocation rates were 6%. And this was originally presented at AUKUS, and I moderated this session. And the thing that really jumped out to me is in their cohort, they found if the fusion extended to the sacrum, there was an 8 times increased incidence in the risk of dislocation. This was a paper I presented at AUKUS. It's just now being published in the Journal of Arthroplasty. Jonathan and I looked at over 6,000 total hip patients that had had a spinopelvic analysis to determine what is the incidence of patients that have a stiff lumbar spine. And it was very interesting that we found that 81% of that database that had a stiff lumbar spine did not have an instrumented lumbar fusion. And as you can see on the image on your right, those are the subjects that actually have a biological fusion. And just because you see instrumented hardware and a spine fusion, not all of those patients have a stiff lumbar spine, again, as defined as going from standing to flex seated, having lumbar flexion of less than 20 degrees. And only about a third of the patients that had instrumented fusions actually had stiff spines. So it's not just subjects that have a lumbar fusion that are demonstrating adverse spinopelvic mobility patterns, and all patients with an instrumented fusion, only a third demonstrated very stiff spines. And I love this quote from Andrew Shimon, because there's the question, should you analyze all of your total hip patients? And in his opinion, and also mine, if you don't look, you don't see. So if you're going to dive into this, well, what angles should you measure? And I think in the beginning, 3 or 4 years ago, there were so many angles being measured that it actually deterred many surgeons because it was just too confusing. And they lost interest because it was just a bit too hard to figure out. And I think now there's much more understanding, and it's a lot simpler. So what do I do in my office? For every one of my total hip patients, we get the standing sagittal lumbopelvic radiograph and the flex seated, and actually I measure about 4 angles. And what are they? Well, number 1, I measure the pelvic tilt, both in the standing and the flex seated position. And pelvic tilt is measured by drawing a line from the anterior suprailiac spines to the anterior aspect of the pubis and connecting that with the vertical line. Sacral slope is measured by drawing a line along the superior end plate of S1 and connecting it to the horizontal line. Lumbar lordosis is measured by drawing lines on the superior end plates of both L1 and S1. And lastly, the pelvic incidence. And initially, I did not measure this, but now knowing that it tells me about sagittal balance, we now measure that. And it's not too hard to do. You draw a line from the center of the femoral head to the midpoint of the S1 sacral end plate, and then a perpendicular to the end plate. So why measure pelvic incidence? Well, I've already shared that with you. I want to know about sagittal balance. And again, the standing lumbar lordosis for the spine to be balanced must be similar to their pelvic incidence. If you have a mismatch between the numerical lumbar lordosis angle in the standing position versus the pelvic incidence more than 10 degrees, you have sagittal spine imbalance. And if the difference is greater than 20 degrees, you truly have a severe sagittal spine deformity, or what's called a flat back deformity, and these are the patients that in the studies have been shown to have an 8% dislocation rate. So let's just look at some patients that have good sagittal balance. And here are two of them. And if you look at the standing lumbopelvic radiograph on your left, you can see that the difference between the lumbar lordosis and pelvic incidence is only 3 degrees balance. The patient on your right, the difference between the two angles is only 1 degree. So good sagittal balance. Now here are two subjects that have sagittal spine imbalance, and there are two varieties of these. If the pelvic incidence minus the lumbar lordosis is a negative number, particularly more than 10 degrees, you have a hyperlordotic case of imbalance. And you see on the left here, the lumbar lordosis and the pelvic incidence, it's actually minus 36 degrees. Now on your right is the one that really grabs our attention, because these are the ones that have the higher dislocation rates. And you can see the pelvic incidence minus the standing lumbar lordosis, there is a 22-degree difference. These are, again, are the ones with the flat back deformities that have the 8% dislocation rate. And I again want to emphasize that there are wide variations in all of these different measurements. And if we go back to that Pierpont article, yes, they gave us the mean levels of all of those things. But let's just look. While the mean sacral slope is 42 degrees in that cohort of over 1,500 patients, look at the range. The range is actually a 90-degree range. Lumbar lordosis, the range is over 100 degrees. And again, this is why I think it's imperative to look. If you don't look, you don't see. The variations are so wide. In my opinion, the spinopelvic analysis preoperatively is important. Now, in the future, obviously, I think that everyone ought to be doing some sort of preoperative lumbopelvic mobility analysis to determine the ideal individualized cup position. You don't want to put the cup in the same place for all patients. But if I can't hit the target in the operating room, that analysis is of no value. So we also need improved technologies to help us hit the target. And if we actually look at this study out of Harvard by Callanan, when they looked at over 1,800 hip replacements done at their center, how often did the surgeons accurately place the cup hitting both the inclination angle as well as the anteversion angle? Only 50% of the time. And therefore, there are now multiple delivery tools to help the surgeon hit the desired target. And you can use patient-specific guides, which is what I use. You can subsequently go ahead and use robotics, computer navigation, and in the future, augmented reality. I will close on just showing you some cases in which the new OPS Insight can be of value. This is now in America, FDA approved, and hopefully later this year, all U.S. surgeons will have access to it. I'm actually going to start with someone that doesn't have an adverse spinopelvic mobility pattern. Here's a 69-year-old male with advanced osteoarthritis to the left hip, no previous spinal surgery. If we look at those risk factors in this patient, he does not have any of them. His standing pelvic tilt is less than minus 10 degrees of posterior tilt. His pelvic tilt change from supine to standing is less than 13 degrees. His pelvic tilt from standing to flex seated is less than 20 degrees. He has excellent lumbar flexion of 47 degrees, and his spine is sagittally balanced with a pelvic incidence minus standing lumbar lordosis mismatch of only 2 degrees. So ideally, this is a patient we all like to do total hips on because 0 of the risk factors are present. Now, if we actually look at the new OPS Insight, here you can see his supine cup inclination is 43 degrees and 25 degrees of anteversion. Now, as you can see over on the right, he only has about 9 degrees of pelvic mobility. And here you can see this patient's individual pelvic tilt from extension to flexion, and you can see no intraprosthetic impingement either anteriorly or posteriorly. And this was a patient in which total hip was performed, a pretty standard total hip, and patient did well without complication. The next case I'm going to share with you is actually the first OPS analyzed case that I ever did. And I did it in 2017, and it was the Monday of the week of our academy. And Professor Shimon was going to present at the academy and was kind enough to stop in Denver along the way and proctor me on my first case. And this was an 87-year-old female with advanced rheumatoid arthritis of a right hip and severe degenerative lumbar arthritic changes, but no history. And I just placed the 2 arrows to catch your eye. I tell my fellows, beware of the owl eye pelvis. And what do I mean by owl eye? It is the extended pelvis. And when you see really on being on a standing AP pelvis or a supine AP pelvis, and when you see the dimension of the obturator foramina greater from top to bottom than medial to lateral, you have a posteriorly extended pelvis. Well, now look at her risk factors. Oh my. If we look, her standing pelvic tilt, 21 degrees posteriorly. Her pelvic tilt change from supine to standing, 23 degrees. Standing to flex seated, 20 degrees. Lumbar flexion, 20 degrees. And her spine is unbalanced with a 31-degree mismatch between pelvic incidence and lumbar lordosis. So this patient, all 5 of the risk factors that I have discussed are present in this patient. Now, if we look at her cloud-based OPS Insight, and we'll go ahead and let's place her cup at a traditionally accepted position of 40 degrees of abduction and 20 degrees of anteversion. And if we look over to the right, in this system, both in the right and in the far left, it is nice that the engineers alert us surgeons of all of the risk factors, and they're all highlighted in red. So if we go ahead and look, you'll see here much more pelvic tilt from extension to flexion. And here, if you look, you will see that this patient has prosthetic impingement posteriorly. And you can actually go ahead and rotate, and you clearly can see the prosthetic impingement posteriorly, which causes anterior edge loading, a risk of anterior subluxation, as well as dislocation. So what can we do here? Well, this patient needs the cup in lesser degrees of anteversion. So in the system here, we initially have adjusted the cup to an inclination of 37 and a cup anteversion of 16. And you can already see here the amount of posterior impingement is lessened. But now, again, here you see the posterior impingement. Then we subsequently go ahead and take the cup to 37 degrees, and we have reduced the anteversion. But now we've created another problem, because here with the cup in this position, you are impinging both anteriorly as well as posteriorly. And again, we made further adjustments, and here you can see when you place the cup at 41 degrees of inclination and 15 degrees of anteversion, and please note here, with that supine cup position of 15 degrees of anteversion, functionally, you still have 32 degrees of anteversion in extension. But by making that positional change, you now can go ahead and see that we have eliminated the impingement both anteriorly as well as posteriorly. And here's a postoperative radiograph, and with all those risk factors that I knew nothing about back in 2017, I got lucky, I think, here. And she has had a very successful result, but I will tell you, if I see this patient today with all those adverse risk factors, in my practice, she will get a dual mobility device primarily. And I'm now going to go ahead and go live to the cloud here.
Hey, Doug, while you're bringing that demonstration site up, just a couple of questions that have come through that I'll try and get your opinion on. I think, first and foremost, thank you for that presentation. I think that's a very good summary of some of the traditional challenges in accounting for adverse spinopelvic mobility and some good insights into perhaps some contemporary ways of dealing with it. Just some questions here, Doug. So, you know, it's around the imaging protocol. So, you know, clearly there's a sagittal workup here. There's additional X-rays required above and beyond what would be considered normal, perhaps 5-10 years ago in total hip replacement. Are they really necessary? Is there other ways we can judge the sagittal position of the pelvis, perhaps from AP radiology? Is that an accurate measure? Perhaps using some of those ally tips that you described. Is that accurate, or is that not a reasonable substitute?
Well, if you have the EOS system, you can get pretty precise, accurate data by looking at AP pelvises where they are taken in a supine position or a standing position. But at least in my hands, I don't have access to EOS, and while it gives me a rough idea, obviously if I look at a supine AP pelvis and I subsequently go ahead and move on to a standing AP pelvis, I definitely can see if the pelvis is tilting anteriorly or posteriorly, but I don't get as precise amount as far as good numerical numbers. And I need a little help here. So back and I had for the talk, and now I'm a second.
You need the link, Doug, for the demo site?
I'm going to find it here.
There you go. Doug, one more question just while that loads. Got a question here around, you know, you showed a couple of patients that had spinal hardware, significant spinal hardware.
Yeah.
Question that one person has suggested that they've used those sorts of patients with long spinal fusions as a trigger to add more anteversion into their cups. Is that a good rule of thumb all of the time, or is that potentially not the correct thing to do on all occasions?
probably in most cases, that is the case. But again, there's wide variability. And if you have a patient that is a big forward flexor from standing to flex seated, you need to antivert your cup more. But I'll tell you, in my journey, Tristan, I started out thinking this was an issue only for those people that have arthritic stiff spines. And after hearing presentations by Professor Lazenac from Paris, one of the world's expert in this arena, and Andrew Shimon, I've learned that I truly can't predict with a high degree of accuracy exactly what their adverse mobility pattern may be. So, my answer to that is get a standing sagittal and a flex seated. And if you measure the pelvic tilt, and if it's more than 20 degrees anterior, that is going to uncover your cup posteriorly, and you need to go ahead and place your cup in more anterior.
That's good advice.
Is a system that can tell me exactly how much I want to go ahead and increase the anteversion in that patient. But most of the instrumented spines, when you do the flex-seated view, they are anterior tilting. And if that is the case, then you want to increase your anteversion.
Perfect. So, well, let's move into the live demonstration, if you can, Doug, and show you how you
hopefully everything is live here. So this is a patient, and here is the screen. And again, just to point out a few things, everything that I need to worry about is highlighted in red. And if we go ahead and look over here, and we look at some of these risk factors, the patient has two of them. She has posterior standing, or posterior tilt of her pelvis and standing of 14 degrees, and she's a big anterior tilter from standing to flex seated 30 degrees. So if we go back to that patient of mine that clicks, that's exactly what my patient did. And so based on those numbers, I would predict she is going to have very little anteversion in a forward flex seated. So if we look at a supine cup inclination of 37 degrees and anteversion of 16, well, when the patient functionally is an extension with that standing, look at her anteversion functionally is not 16, it is 25 degrees. And if we go ahead and we actually look, this is this patient's mobility pattern. And here you can see her pelvis from extension to flexion tilts anteriorly 30 degrees, and you can clearly see where this patient is impinging anteriorly. And if we go ahead, and I'm just going to and put this patient here, the motion will bring her, then you can go ahead and actually pelvis and rotate it in any plane that you desire. And if you want to see exactly where that impingement is, you can go ahead and look at it any way you want. And if you'd actually like to go ahead and look at it in the anterior plane, the same thing, you can rotate and you can subsequently see exactly where the impingement is. You want to go ahead and in greater detail, you can clearly go ahead and see that. And as we look at these numbers over here, for those of us that are interested in, I give you a lot more additional data. And again, here you can see her spine is balanced. She does not have a major mismatch. You can see what the lumbar flexion is. You can see all of the different dynamics. And also, it's very much based on the CAT scan, can help you with your femoral planning because they tell you exactly what the length of the limb is, what the length of the femur is, what the length of the tibia is. So again, the predicted osteotomy level. So all of these things are extremely valuable here. So let's go back to this position. So what do we want to do? Look at the position of, or the functional position of her cup. She only has 1 degree of anteversion due to all of that forward pelvic tilt. So what are we going to do? Well, I think the first thing that we need to go ahead and is we need to go ahead and give her some more anteversion. So watch as I am increasing the anteversion, you can actually see how her pelvis or her cup actually tilts. So is this good enough for her? I don't know. Go ahead. And now we'll rerun it with her cup in a 30-degree anteverted position. And you can see when I do that, and if we stop it in deep flexion with 30 degrees of supine anteversion, she has functional anteversion in a flex-seated position of 15 degrees, which is what Dr. Lewinnick liked. So, but you can get carried away. And if I per anteversion, we'll go to 36 degrees, and you've already seen the system has alerted me that, Doug, that is too much. Now I have taken someone who was having anterior impingement, and now they are going ahead and impinging posteriorly.
Hey, Doug, sorry to interrupt here. The question has come through about lip liners. So in this situation, there might be a temptation in some of the orthopedic community to use a lip liner and place it posteriorly to add some posterior projection there. Do you want to maybe go in and simulate that lip liner and highlight the effect there?
So let's go back and we'll take this back to, let's just say 19 degrees. And I still have some anterior impingement there. Now, I can go ahead and change the parts. So right now, we have a ceramic liner selected, but if we would like to go ahead and use an extended posterior lip, we can change that, and then we can see what will happen. So here, now the patient has an extended posterior lip. She's not impinging in either direction with an inclination of 37/19. I mean, if I want to go ahead and actually look at the any other implant that I want, and we're going to go to the femur in a minute, but again, I can go ahead and I can change the stem or the cup I have in. I can go ahead and, whoops, I didn't want to do that. But if I go ahead, I can change any of the liner options. I can change my head options as far as ceramic or metal, head diameter, neck length, all of those things I can go ahead and change. So now I'd like to go more to the imaging. All of the imaging that we have is available to you on the OPS Insight. And here's the actual desired implant position. Here is the actual postoperative rendering, here with a size 6 Metafix stem. And preoperative radiograph. See all of the sagittal radiographs that you obtained. Here the standing. Here the flex seated. step up. And another new thing that I'm quite intrigued with is we also can go ahead. Maybe I'm going to reset here a bit. Kristen, any?
Yeah, just click on the STEM tab there, Doug. Up the top where it says Dynamics, Cup and STEM, just click on the STEM tab.
All right. Here we go. Okay, so now this is radiodensity bone mapping. And I think it was the Japanese that started some of this sometime in the last decade. But in general, it gives us the density of the bone. Blue is softer, less supported bone. Green is a desired amount of bone density. And red is when you're really up against very, very dense bone. And we're learning how to use this. And I hope 2 years from now, we're going to be able to have data that will tell you if you have a certain amount of red present, you may be at risk for femoral fracture. At ISTA, back in last fall, I presented some of the data where they looked at bone density mapping, and the patients that had a more blue or softer supporting bone anatomy had a higher incidence of stem subsidence. And you can go ahead and look at this in the AP. Now you can see the density along the posterior aspect of the femur and also against the lateral aspect. And we can play with this. Let's just say, hey, we're going to go to a bigger stem. We're going to go up 2 sizes larger. It will subsequently then go ahead and change our bone density pattern, because now we have a larger stem and you have to remount more bone to get to that hard cortical bone. And here you can see a lot more densing that you see here, particularly posterolateral. Now, if we go back, and we'll maybe reset here. If I look at that original metaphyx stem that we had, we have a lot of blue. So is this the right stem for the patient? And again, we're learning. Let's just go ahead and say, you know, I'm going to try a different stem. Let's try the newer TriFit CF filling stem. So now it's loading, and the first thing that I see, at least at the junction of the proximal and middle thirds, I'm getting a little bit more green. But when I go over now and look at the stem, and again, the great value of the CT scan, I don't think that I'm really getting some of the fit and fill that I want with the size 6 stem. So let's, for the sake of time, we'll go up a couple stem sizes, and I think you can see here, now I'm getting a better fit and fill, and now I can then go ahead and see the bone density changes that has occurred with this stem. But now, in going to this stem, you can see I am not duplicating this patient's offset. Well, what can I do? Well, I've got the standard C in. I'm going to now the lateralized stem. And as I go to the lateralized stem, you can see that I have increased my offset. Now I'm actually 3 millimeters more than native. And I could have maybe gone back to the standard. I could then go ahead with the standard. I could go to an offset liner. And all of these different permutations that you can play with. But I can also go ahead and adjust my cup position, because in this rendering, the cup was positioned 2 millimeters off of the inner table of the acetabulum. So I'm going to say, well, you know what? To get rid of this extra offset, I'm going to acetabulum down to the inner table. And in doing so, I now have perfect leg lengths and I am duplicating the native offset. So I hope this has shown you how you can go ahead and play with all of these different things. I can go ahead and look at the cup in the coron. I can look at the cup in the sagittal plane. Look at my stem. And here you see the stem here in the stem plane, meaning we're actually cutting right through the middle of the stem. I really like that fit. I can actually look at it, how it's going to fit in the sagittal plane. And here I can go ahead and I can look at where I'm at in the actual axial plane. Fit and fill going to be at the level of my osteotomy. So I think you can see that there is a plethora of things that I can analyze preoperatively. With this, I walk into the operating room with so much more knowledge than I typically have, I think, to improve the results of my hip arthroplasty. So I hope this demonstration has been of value to all of you, and I'll certainly open up to any additional questions.
Yeah, thank you, Doug. I think that was a fantastic demonstration of the sheer amount of information that you can glean from this particular platform. But pardon the pun, but we are impinging on our 1 hour here. In fact, we've just past it. But I'm going to use my moderator privileges here to extend it for a couple of minutes because we do have some questions. And I guess we've got the inevitable question here, Doug, which always seems to come up. But given this patient's adverse spinopelvic mobility in both flexion and extension, you showed a demonstration of different liner types. We have ceramic liner. We went to a lipped liner. Would you consider a dual mobility in this particular scenario, noting that I guess she's adverse in both directions, or would you be happy to just change the orientation of the cup and stick with a more traditional bearing?
Well, I will tell you, I wanted to demonstrate the system to you. And as long as I did not have offset issues, because if you go to a dual mobility, you don't have the offset, or let's put it, increased offset options that I have if I'm not in a dual mobility. But again, this patient has 2 major risk factors. She impinges both anteriorly and posteriorly. With those 2 risk factors, if I were doing this patient today, she would get a dual mobility primarily. And I don't know exactly how many risk factors should make you go to a dual mobility, or how far out those risk factors are from the safe zones to do that. I have a research study going, and if I have 2 risk factors, I have been routinely putting in a dual mobility primarily. And I gave a lecture at the ACAS Symposium on why not dual mobilities in everyone. And while the new modern dual mobilities are doing very well, there are still risks of intraprosthetic dislocation, which is a big problem. Some of the older designs have had wear issues. I think where I want to go with my practice is I want to have a reason to use a dual mobility device. These are more expensive devices. We all need to look at cost containment. But now I think I actually have information to help guide me on when I'm going to do a dual mobility.
I think that's good advice. I think one final question here before we let people start their day on the other side of the world and finish their day on this side of the world. Can you just, given your experience now evaluating a few cases, can you comment on, a case like this? How much time, given its complexity and highlighting, various forms of impingement, how long would you expect to spend planning a case like this versus perhaps maybe a more straightforward case with no impingement and no adverse spinopelvic mobility? Can you give the audience a flavour?
Well, I'll tell you, I'm going to look at this screen on every total hip that I do, and I probably would spend less than 5 minutes. Like on case one that I showed you, that gentleman that had no risk factors, I'm going to take a quick look at this, and I'll probably spend less than 5 minutes. On a case like this gal, a case like the second case that I shared with you, I probably, when I have played with this, spend about 10 minutes. And as soon as I have it the way I like, if my screen is still up, I go to the lower right-hand corner and hit validate, and all of that information is electronically sent to Sydney, and my patient-specific guide is then developed. It's a very simple thing to do. But even in complex cases, when I've played with this, I don't spend more than 10 minutes. Okay.
So it sounds like we're spending more time on the cases that perhaps need more time and less time on the cases that essentially don't need it.
But I will tell you, Tristan, on every case, I am going to look at this screen. I mean, it's not, if I just look at my sagittal radiographs and everything looks fine, well, maybe I don't need to spend time doing this. That's not true. I will still go ahead and it's actually kind of fun, and I encourage, because this system is being used in Europe and being used in Australia, it is not yet in use in America, and for American surgeons that are on this WebEx, I think you'll want to spend a fair bit of time playing with it and looking at all of the different features. And just the other day, I was doing a little rehearsal of this and was playing with it. And there were 2 or 3 things that I didn't know existed in the system that were pointed out to me. So it has so many different things that you can look at to make sure you walk into that operating room really well prepared.